Our next speaker is Dr. Carlos Mora. He's an assistant professor of neurology. He is our director of neurology education, actually, for the MS Center. He's widely published. He just published an article. I didn't read it yet. I'm sorry. I'll read it soon. But one thing about Dr. Mora is he every year is recognized by the trainees, the residents, as being one of our most humanistic physicians. And those of you whom he cares for know what a wonderful personal and humble person he is. So I think it's really appropriate for him to be giving this talk, which is going to be on caring for caregivers.
As Dr. Tornatore used to say, I remember a long time ago, you said, I wish my mom will be here today listening to this introduction. So thank you so much for your words, Dr. Shin. And yes, it's a pleasure seeing you all every year, now the third year. I see all of a sudden at least 200 familiar faces. So I used to say, welcome my second family, ladies and gentlemen. Today, my colleagues, thank you for all your support. And last but not least, my son, who is somewhere here. He's joining. Oh, good. Okay, that also encouraged me to talk today. So, caring for the caregiver. When I was assigned this talk, I said, well, is it challenging? Is it going to be easy? It's going to be totally different. 2 years ago, we spoke about the bone marrow transplant, stem cells, mesenchymal, all that, chemotherapies. Last year, we spoke about geography, nutrition, the 5 blue zones of the world, where people live longer, but actually one of those 5 zones has the highest prevalence of MS in Italy, Sardinia. So no, today, caring for the caregiver. So before the first slide, I just want you to know, before I sat down to prepare this talk, I saw this topic in a different way, perhaps immature. Why? Because basically I just had 4 concepts for the caregiver. Typically, in our clinic, in the room where many of you know, I see, we have been there for about 12 years now, perhaps more. And the ratio, even though they say the ratio female to male in the US is 3:1, no, in the ratio is at least 15:1 and perhaps 20:1. 20 female patients for 1 gentleman. And over the years, I developed in my mind, I never told this to anybody, but I developed this pattern, type of caregiver. I typically say, this is a type 1, this is a type 2, oh, looks like this is a type 3, and more recently, type 4. So you want me to share this, I will do it. And yes, again, these types probably are not true anymore because after I prepared this talk, I said how blind, how ignorant I was. So the 4 types. Type 1 is the coach. In general, because most of the patients are female, the caregiver in general is the husband. So typically type 1, coach, entrepreneur. There he is. As we say, Team Julia. There, Julia, come on, we can do it. So that's type 1. Type 2, perhaps after several years, perhaps the disease has been progressive, he looks a little bit tired, perhaps a little bit exhausted, depressed, but we just inject some stamina, and there he cheers up. There he's back to business. Entrepreneur, coach again, type 2. The real character, very unusual, but it does exist. Type 3. My patient sits in front, she's telling me everything. There he is. Before iPhones, he was reading the newspaper. Then he began to bring his laptop. Now he sits down with the iPhone. And there he is texting and testing. And I say, sir, do you have a question? He says, me? Oh, no, I don't. Keep going. So that's type 3. More recently, type 4. Who is type 4? I call him, or her actually, the warrior. Sorry, you are here today, but your appointment is not today, it's tomorrow. So how come you didn't tell me? Or why is Dr. Mora so late? I've been working here for 45 minutes. The warrior. And then I kept thinking, there are 4 types. And then one day I thought, no, wait a minute. We human beings, we are not robots. And actually, we rotate because we have also been caregivers at some point. And point is, some days I be type 1. Some days I may be type 2, but then I got the stamina, back to business. So when everything is going so well, we may become type 3. Actually, Many times I say, where is your companion? Where is your husband? Oh, he's working. He really doesn't care too much. That means patient is stable. She's doing well. He is doing well. And type 4, the warrior. So that's the way I saw the caregivers before this talk. But all that changed when Mrs. Bethany Schreiber, thank you so much, invited me to talk about this topic. So, that sentence, her well-being is my well-being. The gentleman looked at me deeply, seriously. Her well-being is my well-being. So if I go ask, how many of you think this sentence came from the patient, and how many of you thought this sentence comes from the caregiver? So I'm not going to ask, raise your hands, 70%, 30%, no. So this sentence was mentioned about 3 years ago. Mr., I cannot say the last name, Mr. Y. Mr. Y he was a caregiver. He passed away not long ago, a few weeks ago, lung cancer. But from him, I learned that key sentence. He looked at her, my patient. He said, doctor, I asked so many questions. And yes, he used to ask a zillion questions because there I was typing my recommendation and there he kept asking questions. Say, could you please, like at this meeting, questions at the end. So I said, listen, could you please stop? Let me finish typing my recommendations. And then he said, doctor, her well-being is my well-being. And then I kept that sentence in my mind, saying, my goodness, there is so much wisdom in that sentence. So it is to him, to his memory, that I dedicate this talk. Caregivers. I'm looking down, it's because our teleprompt is down here. It's not that I'm looking for mice. So a caregiver, you are reading, and yes, we have good screens, but definition, you don't need a definition. You know, it's the person, the significant other, who helps with physical, psychological care for that patient in need. They are often family members, and in general, we say the caregiver, in general, we think about the significant other, a spouse, companion, but not always is like that. There is one slide coming from an Italian study that will show you the diversity of caregivers. They are often family members, and yes, they are unpaid. And here is a definition that they use a lot in occupational therapy. They call them the informal caregivers, the unpaid caregiver. Because the formal caregivers are in general professionals, and in general they are paid. They provide a wide variety of assistance with activities of daily living. There you have bathing, toileting, dressing, transferring, transportation, cooking, going to the pharmacy, social activity, etc. This information is taken from a very interesting paper, Dr. Amy Sullivan and Deborah Miller, from the Mellon Center for MS Care at the Cleveland Clinic, Cleveland, Ohio. They published this very interesting paper at the Journal of Patient Experience, 2015. From this paper is where I got pretty much the template for this talk, among other sources. And they say, you may disagree, 66% of family caregivers are women. Remarkably, 65% of the care receivers are also women. Remember, in our MS clinic, the ratio may not be 3:1, but much higher. Caregiving in MS. So we will talk about these 5 topics: the caregivers, the stages of caregiving, the needs of the caregiver, believe it or not. Yes, caregivers have lots of very important needs. How useful is the multidisciplinary medical team? And this connects with what Dr. Tornatore spoke about, the MS specialty practice, because one of the main goals is that we should provide our multidisciplinary medical team for the needs of patients and caregivers. Last but not least, kind of conflictive abuse. And there you see, it's in small characters, the references. Sullivan in 2013 in her book included a topic, half a page, about abuse. Interestingly, in the paper, 2 years later, 2015, same author, they omitted abuse. I don't know exactly why. It's a difficult topic to talk, but we cannot ignore. Abuse happens. Sometimes, actually, the abuse is not just the abused patient, it's the abused caregiver. Experience somehow teaches us a lot. Abuse may come actually from a very stressful situation, especially financial burden. So, caregivers, some demographics. So I got this study. This is an Italian study published last year, Frontiers in Psychology. They did a significant interview among 248 individuals. These were 4 groups, 62 participants each. That means 62 patients with MS, 62 caregivers, and the other 2 groups were actually non-caregivers. And there you see the diversity that partners basically entail 63%. So whenever we say, oh, the caregiver is the spouse, they signify, no, the 63%. And these statistics, although coming from Italy, pretty much matches what we see in daily practice. Parents, 23%, almost 1/4. Yes, if we recall, many of us see patients coming with 1 or 2 other parents. Siblings, I remember some patients who come with siblings. Children, yes, the patient may be actually be escorted by his son, daughter. Friends, we see that as well, 3%. And then you have at the end, professional caregivers. And remember, they are the paid caregivers. Okay, continue. What is the impact that in general caregivers perceive? Basically, some impact on social relationships and some impact on physical and psychological health, their own. So on the top, impact on social relationships, many caregivers may perceive that a sense of imbalance in their relationship with the patient, with the family member who is receiving care. They feel sometimes like the forgotten member of the relationship. Why? Because family, friends, acquaintances keep asking about the well-being of the patient. Remember, we're all humans. Impact on physical and psychological health. Few caregivers have the benefit of any formal training, especially physical, body, to execute physically stressful activities. In some patients who are unfortunately progress towards secondary progressive significant disability, the caregiver at some point is forced to think on how to deal, how to handle the physical needs of the patient. This, of course, may lead to emotional impact. And it is not uncommon. Some caregivers at some point even verbalize that they have had to neglect their own health care and needs. Impact on finances. So this is important. We decided to bring numbers because we cannot ignore, and this is reality. Again, every slide has the reference, the bibliographical reference from which I took this information. Again, Sullivan's paper. 58% of caregivers, more or less, are employed. The majority are men. Median incomes may be 15% lower than non-caregiving families. A caregiver is more than 2.5 times as likely to live in poverty as non-caregivers. And the average family caregiver may spend at least $5,500 a year on out-of-pocket expenses. For them, for many, it could be 10% of the median family income. This is a map, United States of America, MS prevalence. It means it's how much MS we have in the country. In the United States, commercially insured population. So make no mistake, there are several patients non-insured who were not involved in these statistics. And this was published in a paper, Neurology, we call it the Green Journal, 2016. John Corbey, Dr. Campbell, and others, especially from Denver, were involved in gathering all this data. Why do I bring this? Because it is important to understand the economics of burden, financial burden in MS. We need to understand how much MS is there in the country. Average, for every 100,000 individuals living in this country, there are 150 patients with MS. 150 per 100,000. That's the average prevalence in the country. It may be low in the West, almost 100 per 100,000. It may be almost double in the upper, like Massachusetts, New York, close to 192 per 100,000. That means that according to the last census, we have at least 400,000 patients with MS in this country. and probably is getting to 450,000 patients in the United States of America. Why is that important? Because of the cost burden of MS in the United States. Statistics, and this is coming from a journal called the Journal of Medical Economics, 2013. So yes, we don't only read papers about biology, histology, pharmacotherapy, and cell stem transplant, we also read papers about economics. Journal of Medical Economics, 2013, Adelman, and they concluded these interesting sentences. The total all costs, healthcare costs for MS went from $8,500 up to $55,000 per patient per year. Direct cost comprise or included or entail 77%, including prescription drugs. Direct costs also entail all what means visits to the ER, visits to the clinic, MRIs, admission to hospital, IV infusions, etc. That's the direct cost. The indirect cost, usually the definition entails is absenteeism, I mean the money that is not perceived or the income that is reduced because you are out, absent from work, short-term, long-term disabilities. Compared with direct costs for other chronic conditions, MS ranked second behind congestive heart failure, heart disease, CHF as we call it. The stages of caregiving. So we have to be careful because when we had no therapies for MS, or when the therapy for MS was still just beginning, see, those were the chaos, dark, still in the darkness. So basically, at some point, there were three phases, which pretty much were similar to the phases that they describe it in Alzheimer's disease. The caregiver and the patient, the first phase, encounter, means I'm told I have MS. The caregiver, oh, she does have MS. Now what? Encounter, phase one, shock, trauma. Second, enduring, means I adapted, and this enduring may last years, decades. And then the third phase, exit, because years ago, few decades ago, there was inexorable progression for many patients. This basically would mean the patient was transferred to a nursing home or required significant assistance. Well, not anymore. With now available 15 therapies, and especially those of us who were in Berlin, came even more and more optimistic with all the new therapies for MS. Just my predecessor in the talk, Dr. Osborne, gave this very important talk about remyelinating therapies. We are only waiting results. So now we have modern concepts of caregiving experience, and that was taken from another paper. Appleton, Scandinavian Journal of Caring Science. So believe it or not, occupational therapists, psychologists, social workers, they read a lot about this, that we clinicians perhaps do not read about too much. And they conclude there is an initial phase, acceptance and appreciation, commitment, becoming the caregiver, living with loss, anger, grief, why me, why now? Many of our patients are young female, between 20, 35. They are just beginning, career, marriage, life, and I want to have a child. Why me? What's going to happen? So anger, grief. Then, as they process, and again, with the reassurance that we provide, now that we have more and more therapies, there is a process of resolution. Shifting sands means when there is progression of disease. And that's when we say your MRI is showing more lesions, you are having more symptoms, we feel the medication perhaps is not working as we expected, we need to have the talk and switch or add something else. Setback with services, the frustration when the system does not work, be medication, be transportation, be insurance, ourselves, the doctors. The needs of the caregiver are summarized. Again, these are the Sullivan's publications from 2013 and 15. Emotional support. Yes, the caregiver needs lots of emotional support as well. There are caregiving essentials, especially physical training, psychological training, and the wellness activities, especially also to take care of herself, himself, as we will see in the next slides. But this is what they call a trifecta. I mean, three essentials for the caregiver: emotional, caregiving, and wellness. So we can say significant and healthy human relationships are successful only when they are reciprocal and mutual. The care recipient may need a great deal of assistance, yes, but the needs of the caregiver must also be met in order for their relationship to remain healthy. And this is important, and not only in patient care, it's pretty much in every aspect of human relation with somebody else. So they have also this definition, the caregiver burden, a multidimensional response to physical, psychological, emotional, social, and financial stressors associated with the caregiving experience. And this came in 2005 by Bush in the Journal of Neuroscience Nursing. Tips for the caregiver to avoid burnout. So there are basically 10 tips. So the first 5 are here. Become educated about the disease. Ask questions, a zillion questions. No problem with us. No question is a stupid question, and all questions are important. Take care of yourself. Avoid becoming unhealthy emotionally, physically, and spiritually. Practice healthy living, diet, exercise, become involved with your own interests, and get enough sleep. Yes, sleep hygiene is extremely important. Having your TV on in your room, that's not good business. Okay, stay social. Connect with others in similar situations, like this meeting, as a matter of fact. Maintain other important relationships. Talk to your children, talk to family, talk to close friends, even if they are far away. Take advantage of all the media that we have nowadays, even if they are in faraway countries. Accept help. The best way to avoid burnout is to accept help, and believe it or not, there are many people out there who want to help. Okay. Tips for caregivers, the next 5. Acknowledge your emotions. This is not easy. Many times the patient, the significant other, is so sick, so compromised, that we tend to be brave, we tend to hide, keep it for ourselves. So there are normal reactions to your situation. The next, allow for a healthy expression of your feelings with each other. It's not easy either. Sometimes you may need the help of a counselor or an expert, therapist. Give for your caregiver caregiving holidays. You may say, okay, I'm going to be out at least a few hours, maybe one day, maybe a holiday, while you find a way that others may come and help. And also, this goes 2 ways, because I had this patient, and she may be here, and she said, please send a message to my husband. He treats me like a queen, but he doesn't allow me to do anything. Please send him a message. So encourage healthy independence of your loved one. I don't see her. Okay. Seek help through your local organizations, and that's why the National MS Society is very important on top of other. The occupational therapists, especially in our team, we talk a lot about the need for social workers, and yes, social workers are extremely important, but occupational therapists, OT we say, typically we say PT, SW. Well, OT, occupational therapists, are extremely important. And there are several books. This is a series, the Rosalind Carter Center, where occupational therapists, social workers, psychologists came with all the needs. And one of the books is this, Multidisciplinary Coordinated Caregiving. In this book, there is a chapter, and one of the authors shared with us these ideas: inclusion of caregiver perspective, the risk of the informal unpaid caregiver injury, the topic of patient safety and complaint about quality of care to the corresponding authorities, advocacy on gender differences, especially, I remember the comment was that if the patient, her husband, was in the hospital, they realized that having the professional caregiver during the daytime in the hospital actually will increase or improve care. And that at some point, that person was kind of more recognized if the caregiver would be a female. Addressing changes in health function, hospitals, caregiver discrimination in employment settings, and referral for services. Almost done, multidisciplinary care model for patients and caregivers. So this is what we need. It's going to be important, not only for the patient or care recipient, but also for the caregiver. The model, you're going to see it in the next slide, allows for several practitioners, and that includes the doctors, to interact with the caregiver to assess and determine the optional intervention. And there you have medical, that's us, rehabilitation, administrative assistance, national organizations, and mental health. In conclusion, basically, remember, care for somebody, caring for a loved one can be profoundly fulfilling, but it can also be significantly overwhelming, physically and emotionally, and isolating. Caregivers must learn to take care of themselves and accept help. Last but not least, assess for abuse, physical, emotional, financial. And I believe that if you want references, this talk is going to be uploaded to the website. And at the end, resources, the National MS Society, United Way, Home Care Agencies, National Family Caregivers Association, and the Well Spouse Association. Thank you so much.